The next interesting session would be on symposium on the controversies in acute MI and ACS. The first talk would be on heparin versus bivalirudin in acute MI. Dr. Sarat Chandra will be talking on this.
Two friends, Dr. Rath and Seshagiri as chairpersons here. Thanks, Dr. Srinivas, for this opportunity. Bivalirudin versus heparin is a standard question. Should you use bivalirudin? Is it really worth it despite its slightly higher cost? What are the issues in this? Let's look at the data. Now, hemorrhagic complications have emerged as an independent risk factor for subsequent mortality in patients with ACS and in those undergoing PCI. Now, we know that once a bleeding complication occurs, not only the in-hospital mortality is slightly increased, the long-term mortality is also increased. The reasons we are going to see. Major bleeding also considerably prolongs the hospital stay, sometimes necessitates the usage of various things, including a stent graft for closing a pseudoaneurysm and so on, and thus it represents an important source of additional expenditure to the patient. The mechanisms through which the major bleeding might increase mortality in patients at high risk for cardiovascular disease are numerous, which includes a fatal hemorrhage. Hemorrhage at a particularly important point like an intracranial bleeding might itself produce mortality. Direct effects of volume depletion, which can result in hypotension, ischemia, arrhythmia, shock, and so on. The very important point is the transfusions of relatively old blood, which is given many a time in the intensive care units as soon as a bleeding occurs by older as well as relatively younger doctors who have not appreciated the importance of unwanted blood transfusions. And these blood transfusions in some way or other lead to systemic vasoconstriction, inflammation, apoptosis. These are all the various theories by which probably blood transfusions affect. But this is now a very well-established thing that same degree of bleeding, those guys who received blood transfusions fare much worse than those who have not received blood transfusions. And of course, a most important point is many a time there is a tendency to stop the antiplatelet agents in these patients with the hope that the bleeding might stop. In reality, it really doesn't happen, but it increases the chance of stent thrombosis and the subsequent mortality. Now, bivalirudin is one of the important ways to reduce the chances of bleeding in these patients who undergo PCI, and we should know a little detail about it. Bivalirudin differs from the unfractionated heparin in several ways. The bivalirudin does not require a plasma cofactor like antithrombin 3, which is necessary for the action of heparin. The bivalirudin acts at both the free fluid phase thrombin as well as the fibrin-bound thrombin. The unfractionated heparin cannot act by its own by a particular mechanism on the clot-bound thrombin. And bivalirudin inhibits thrombin with high affinity and specificity. Bivalirudin is not inhibited by platelet factor 4, which is the case in the case of unfractionated heparin. And heparin activates platelets, but bivalirudin does not. So by all these mechanisms, bivalirudin scores over unfractionated heparin in the sense that its action is very short-lasting. And the moment the PCI is over, you can stop bivalirudin infusion and you can remove the sheaths very early. Now, some of the important trials one should look at, the REPLACE-2, which is not obviously an acute MI-related trial. It is in high-risk patients, both emergency patients as well as elective patients of PCI were tried. It's a large trial. It has been published quite some time back. And at the end of it, what it has shown is that there is a great reduction in the bleeding complications of these patients, but it has not translated into a reduction of mortality. The ACUITY is another trial, which of course had 3 arms, where they gave unfractionated heparin along with 2B3A blocker and bivalirudin along with a 2B3A blocker and bivalirudin alone. And it has been clearly shown in the ACUITY trial that bivalirudin alone reduces the rate of major and minor bleeding, but once again, a translation into reduction of mortality has not been demonstrated. The most important trial in relation to bivalirudin is Horizon AMI trial. Now, this is a trial done in a large number of patients where patients, it's a 2x2 factorial design. A non-drug-coated stent versus a drug-coated stent has been tried in acute MI patients. In addition, they have been randomized to bivalirudin versus unfractionated heparin. And here is as you can see here, this is a large trial, 3,600 patients. Now, recently we had in JACC the publication of 3-year follow-up also. The unfractionated heparin along with 2B3A blocker in 96% of the patients, and bivalirudin monotherapy with 2B3A blocker just used in 7% of the patients has been compared. And here, of course, the dosage of anticoagulation is 60 units per kg body weight of heparin, and other things we can skip this. And aspirin and thienopyridine have been used, obviously, in these patients. This is not a prasugrel trial. This is done in quite some time back. And here we can see that the bivalirudin has consistently shown a reduction in the in-hospital mortality, the long-term mortality, the incidence of major bleeding, and the only hitch in Horizon AMI trial is in the first 24 hours, there is a slight increase in the stent thrombosis. This has not been clearly explained why there is a slight increase in the stent thrombosis in the first 24 hours, but actually bivalirudin catches up with unfractionated heparin, and at the end of the follow-up, there is no difference in stent thrombosis between the two. Probably bivalirudin in some way reduces nitric oxide bioavailability and probably leads to vasoconstriction. This is a theory. Probably that's how the slight increase in the first 24-hour incidence of stent thrombosis has occurred. And the early increase in stent thrombosis, as I just mentioned with bivalirudin, may be explained by a peculiar mechanism, but basically what we should understand is the patients who go on bivalirudin must be pre-treated with good doses of clopidogrel. That has been clearly demonstrated in the ACUITY trial. And the final 3-year report from Horizon AMI trial was recently published in NEJM and later even in Lancet in 2011 on June 25th. And it has been shown that there is no difference in stent thrombosis in the long-term follow-up in any of these events, but at the same time, there is a significant reduction in non-CABG related major bleeding, reinfarction, and all-cause mortality. Now it is clear that in acute MI setting, where the patient has been given adequately pre-treatment with clopidogrel, bivalirudin does reduce mortality. There is another publication which came in European Heart Journal about a year back by Reisen et al. It is a retrospective analysis of about 1,20,000 patients treated in the United States, and this was a retrospective analysis, and it has shown that there is a 49% reduction in in-hospital mortality and 33% reduction in blood transfusions, clearly establishing that if you want to reduce the bleeding complications, it is clear that bivalirudin is an agent of choice. ISAR REACT 3 is another trial which came from the Munich group, where biomarker negative patients, meaning low risk patients, were subjected to unfractionated heparin versus bivalirudin. There is no difference in mortality, but once again significant reduction in bleeding has been shown. There is a BevaFlow registry of India where 439 patients of high risk ACS were treated with bivalirudin, and the minor bleeding complications were just 0.9% with no major bleeding complications. So whether these benefits of bivalirudin will hold good in the era of prasugrel and with usage of newer stents and where the radial approach is used is not still clear, but probably in patients who is a high risk patient for bleeding complications, like what I'm going to show you, this is probably an agent of choice. What we do in our hospital is the niche indications for bivalirudin in our day-to-day practices. The patients who are more prone for bleeding, for example, a older female, a patient with a low body mass index, patients who had a stroke or TIA in the past, active peptic ulcer or recent upper GI bleed, or patients with CKD, and of course the old indication, that is heparin-induced thrombocytopenia. These are all situations where you should go for bivalirudin. Thank you very much.
I think we can ask few questions to Dr. Sarat Chandra. And to start off, I just want to ask you, Dr. Sarat, because in spite of all the data supporting bivalirudin in the use of during PCI, somehow it has not picked up in India. Can you tell what is the reason? I think the use is very less in India, probably less than 5%.
Yeah. The bivalirudin has not become so popular in India. For your information, also in Europe, European cardiologists, they mostly say that we don't need bivalirudin. We are very happy with this. The probable reason is that they go for radial angioplasty more often than not. In the United States, where it's still femoralists are the more common cardiologists you see, their bivalirudin. Probably it is something to do with higher risk of bleeding with femoral route. Probably if you do it in by radial route, the importance of bivalirudin is relatively less. At the same time, if you see the rival study data which has come recently, the radial route has really not made a very big difference. It has reduced the access site bleeding, but the non-access site bleeding, they are still there. So probably given the correct design of the study, you will see that there is a benefit in these patients. We have in Nizam's Institute, we have a lot of patients who are CKD patients, who had recent stroke, upper GI bleed. In fact, today we do, in all the patients who we think are high-risk patients, we go ahead and do an upper GI endoscopy also. And wherever we have an ulcer, which can lead to bleeding later, we would like to go for bivalirudin. The moment the procedure is over, you stop it, you pull off the sheaths, and the patient is doing well.
No, it's probably selective use is more preferred here, unlike in USA where it is very highly used in interventions. And somehow it has not picked up. Probably it has to have a place where it should be more effective. I think one of the cases patients who have got active peptic ulcer and chances of GI bleed because of or bleed is more because of the old age. Probably this is more indicating that case. If you have any questions, please go ahead and ask.
One comment. After the Horizon study only, it was very clearly established that bleeding incidence is much less and more safe. You must remember that with heparin you are adding even 2B3G, 2B3A antiplatelet agent. So both combined bleeding is much less compared to biliverdin. So in future, probably after this study, more and more people will use biliverdin. This is an initial reluctance, but I think it's very clearly established now. Long-term mortality is less, bleeding is almost 1/3 less. Future is for biliverdin.